framework of implementation talks about placing community at the center stage. The first phase of community monitoring was initiated in year 2007 across 9 states of India. The advisory group on community action provided the leadership to the process. And also, there are 3 people which I would like to mention, Amarjit sir, Tarun Seem sir, and Mr. Amarjit, sorry, excuse me, Mr. Chaturvedi, who was the mission director at that time. They also provided leadership to this whole process. Under community monitoring process, we formed over 620 VHSCs, which were, either restructured or reformed across 1,600 villages. And they were trained about their roles and responsibility, which comprises about the entitlement under NRHM and how to conduct community monitoring in the villages. According to National Rural Health Mission, there should be one village health and sanitation community in every revenue villages. Role of VHS is to plan and monitor the activities under NRHM at the village level. The VHSC monitors functioning of ANM to ensure services delivery. This VHSC also ensures the duties which has to be provided by ANM at the fixed health day service. This study has been conducted in Bangri-Posi block of Mayurbhanj district, which has 67% of population of tribal. Literacy rate is nearly 38%, and which was one of the districts under community monitoring of first phase. We took 7 villages which were part of the community monitoring process, and 7 VHSs were selected randomly out of 81 villages which were not part of the community monitoring process. And these were the control villages. And we try to ensure that the ANMs are not common in trained VHSs which are trained under community monitoring process. The parameters were selected for the VHSs under CM was VHSs were at least 3 months old, and they were structured as per NRHM guideline. Members were trained under CM processes, meeting at least once in a month. They are having meeting at least once in a month. The ANM, ASHAs, and Anganwadis are present in the meetings, and VHSC health register were already created. The method which we observed, it was observation interview. We observed nearly 28 health fixed days across 14 villages, which comprises community monitoring villages and non-community monitoring villages over 2 months. And overly, we conducted 40 interviews with mother who had delivered last 3 months. And we had 3 tools for this scoring tools. One was VHSC scoring tools, which comprises all these composition of VHSCs, meeting held in last 3 months, discussion topic what was there, and whether village health register was prepared or not. And then for fixed health day, we had another scoring tool where we try to see that, who are the people present in this meeting, and whether antenatal checkups were done or not, postnatal checkups were done or not, and we had interviewed with mothers. So we can clearly see these are green one is the CM villages, VHSs, and red one is the non-CM VHSs, where we see that, the only difference we see that in CM villages, this SCG member, PRI member, and VHSC members are present in health day, whereas you don't find in non-CM villages, their SCG members, PRI members, and VHSC members are not present. And also, one of the villages we found that, ICDS member is present. And for this maternal health scoring, we had, the scoring was done on the basis of the following parameters: ANC scores, which registration, ANM visits, weight checked or not, BP checked or not. These were the parameters were followed. For INC scores, institutional delivery, delivery during advice, ASHA was, with women or not, risk-related counseling was done or not, NAM advice or not. PNC scores were, PNC checkups and, number of checkups. These were the parameters which we followed under this health services. This is not the percentage, these are the score which we had given to this, and we come up this bar chart. We clearly see that, VHSCs which are trained under community monitoring had, bigger impact on the delivery of services in health days in compared to non-community monitoring villages, which has, registration, weight, abdominal check, TT was, and IFA was the, we don't see much difference, but, like weight, abdominal check, BP, and this registration had lots of impact in this. Whereas you can see the PNC services, again, this was the high, community monitoring villages scored high, like diet, counseling related to diet, checkup, and rest-related counseling were quite high in community monitoring VHSCs.
Is that 2 more minutes, Sunita?
Sorry. When we try to look at the likelihood of, women getting services, in community monitoring VHSCs and non-community monitoring, we found that ANC was women were 7 times more likely to get ANC services in community monitoring VHSCs, and whereas, PNC and NNC was, 5.6 to 6.2. Where we try to look at the, maternal health services, pregnancy registered within 12 weeks was, 70% in community monitoring villages. Whereas, you can look at the, between 12 to 14 weeks, it was in non-community monitoring, it was 65%. And whereas, we see the counseling advice on common problem, it was 90%, whereas in non-community monitoring villages, it was 0%. Whereas, advice on early breastfeeding, again, it's everything, in community monitoring villages, advices was quite high, and counseling was high, whereas, non-community monitoring, we don't see much differences. We came up to the conclusion that in all fixed health days, ANM, AWW, and ASHAs were present, but in CM VHSC villages, PRI, SAG, and VHSC members were also present. In both CM VHSC and non-CM VHSC's village health fixed day, IFA distribution and TT injection is being done, but checkups of abdomen, BP, and measurement of weight is being done primarily in CM VHSC villages. Most mothers receive counseling only in CM VHSC villages, none of them in non-CM VHSC village. Women from CM VHSC village received more ANC, INC, and PNC, which has already evident from the matrix which I showed. And some positive indicators which we came up into, formation of VHSCs in villages is in the villages is promoting the presence of SAG, PRI, and VHSC members during fixed health day. Presence of trained VHSC members improved in range of and quality of services being provided during the fixed health day. Women from villages within trained VHSC receive more services, especially in range of PNC and neonatal care. PNC and neonatal care is known to be low compared to ANC and institutional delivery. The formation of training and VHSC has improvement in range of quality of services given by ANM in the villages. We recommend that formation of VHSC under community monitoring should be adopted for all states. There is need to ensure composition of VHSC as per the guideline. Attendance in VHSC meetings of PRA, ANM, and SAG members should be ensured. More rounds of VHSC member training is required. Community monitoring should be upscaled in all the villages. Documentation of process and outcomes need to be done, and constructive re-evaluation of community monitoring process is, constant re-evaluation of community monitoring process is required. Thank you.
Thank you, Sunita. I think she's raised the very important issue of building capacities among community leaders to manage institutions. We'll now hear our friend Dhananjay on community monitoring as an accountability tool.
They are hyperlinked. Yeah, no problems. Thank you. Just this.
Dhananjay has to leave after the presentation immediately. What we'll do is we'll open up for 1 or 2 questions after Dhananjay speaks. So I think the suggestion of Dr. Srinivas is if only the findings of the study are shared, the methodology could then be visited by those who would like to look at the details data. Okay.
Thank you very much, sir. First of all, I'd like to acknowledge contribution that my colleagues have made while making this presentation, especially Ms. Dipali Yakundi and Dr. Abhay Shukla. So I'm going to present about community monitoring of health services and related trends